Tell me something. Between 1932 and 1972, the United States Public Health Service conducted the Tuskegee syphilis study. 399 black men with syphilis were enrolled in a study and told they were receiving treatment. They were not. They received placebos while researchers observed the natural progression of untreated syphilis. Effective treatments became available in 1947. The men were not offered them. The study continued for 40 years. The Tuskegee study is not ancient history. Its effect on health research participation rates, institutional trust, and vaccine acceptance in African American communities have been documented in research published as recently as 2021. Those who cannot remember the past are condemned to repeat it. George Santayana. Historical exploitation does not disappear, it transmits. Before we begin, an important one. This episode is for educational purposes alone. It's not substitute for professional, medical, psychological, or public health advice, diagnosis, or treatment. Its content draws from an introduction to global community health psychology published by Routledge in 2026 and from peer-reviewed academic sources. Always consult current guidelines and qualified professionals. If you are experiencing a health concern, please seek qualified professional support. Links in the description. Welcome to Global Community Health Psychology, the full course. I'm Dr. Anthony Iyore Anaweokhai, MBBS, MBA, MSc, MPH, PhD. Director of the Anaweokhai Institute for Applied Global Health, Port Harcourt, Nigeria. Series 1, Foundations, Episode 7. Today we cover Chapter 3 of An Introduction to Global Community Health Psychology, published by Routledge in 2026. Chapter 3, Research Methods in Community Health Psychology. To put it simply, how to study health in communities without exploiting them. In this episode, the paradigm shifts from research on communities to research with communities, community-based participatory research principles and what they require in practice, measurement equivalence across cultures and why translation is not the same as equivalence, indigenous data sovereignty and the OCAP principles, mixed methods approaches, and how digital data collection is creating new equity challenges that most researchers are not prepared for. You see, the question is not whether we research communities, the question is whether the communities will be better off for having been researched. Let's get right to it. The most important shift in community health research in the last 50 years is captured in a single preposition. From research on communities to research with communities. Traditional research operated on communities. Researchers entered, collected data, left, published, and the community received nothing. Or worse, received findings that pathologized or misrepresented them. Community-based participatory research, CBPR, operates with communities. Community members are partners throughout in identifying research questions, in designing methodology, in collecting and interpreting data, and determining how findings are used and communicated. This is not a minor procedural change, it is a complete redistribution of power in the research relationship. CBPR principles include recognizing communities as units of identity, not just geographic catchment areas, building on community strengths rather than deficit framing, facilitating collaborative partnerships where community members have genuine decision-making authority, ensuring that research benefits flow to communities, not only to academic careers, and building community capacity for ongoing, independent research and health actions. Research, you see, is formalized curiosity. It is poking and prying with a purpose. Zora Neale Hurston. The purpose must include the community, not as data, as partner. Here is a mistake that undermines more global health research than almost any other, and is made routinely by well-funded institutions with peer-reviewed results. When you translate a validated psychological instrument from English to Etsako or Yoruba, you have not created an equivalent instrument. You have created a linguistic translation. Equivalence is a separate and much more demanding standard. There are 4 levels of cross-cultural equivalence: conceptual equivalence, semantic equivalence, operational equivalence, and metric equivalence. Conceptual equivalence: does the construct even exist in the target culture in the same form? Semantic: does the translated language carry the same meaning and connotations? Operational: is the measurement method appropriate to the cultural context? Metric: do the psychometric properties hold across cultural groups? Achieving full equivalence is technically demanding and frequently underestimated. Research that uses instruments validated in one cultural context and treat them as automatically valid in another is generating data that may be systematically misleading. And policy built on that data may be systematically misdirected. Not everything that can be counted counts, and not everything that counts can be counted. That's according to William Bruce Cameron, sociologist. Before deploying any measurement tool across cultures, ask the 4 equivalence questions first, then design the adaptation process, then validate, then measure. Who owns the data generated about a community? The First Nations Information Governance Center in Canada developed the OCA principles as a direct answer to that question. Ownership, control, access, possession. These principles establish that indigenous communities have the right to own the data generated by and about them, to control what research is conducted and how, to determine access to that data, and to physically possess their own data, rather than ceding it to external institutions who then decide what to do with it. OCAP represents a fundamentally different model of data governance, one in which the community, not the institution, holds authority. And it's increasingly recognized beyond indigenous contexts as a model for all community-based research. Knowledge is power, information is liberating. Kofi Annan, former UN Secretary General. If knowledge is power, then the control of knowledge is the control of power. The question every researcher working with communities should be able to answer: who owns this data? Who benefits from its analysis? Who has the right to decide how it's used? Community health phenomena are complex, and complex phenomena require complex tools. Quantitative methods capture scope, capture frequency, and capture testable relationships. Qualitative methods capture meaning, capture processes, capture context, and capture the lived experiences that numbers cannot represent. Mixed methods, the systematic integration of both, provide the most comprehensive picture. Explanatory sequential designs collect quantitative data first, then use qualitative methods to explain what the numbers show. Exploratory sequential designs collect qualitative data first, then use it to design more culturally appropriate quantitative instruments. The most sophisticated mixed methods designs use transformative frameworks that explicitly center social justice and community empowerment. Qualitative researchers study things in their natural settings, attempting to make sense of or interpret phenomena in terms of the meanings people bring to them. Norman Dezin and Yvonne Lincoln. The goal of mixed methods is not a methodological completeness for its own sake. It is the fullest possible understanding of the human experience you are studying, so that the interventions you design are grounded in that full reality. Digital data collection has transformed what health research is possible. It has also created equity challenges that most research training programs are not yet addressing. Mobile health surveys reach populations that traditional surveys miss. Passive data collection through smartphones capture behavior as it actually occurs, not as people recall it. Social media data opens new windows on population level health behavior patterns. But digital data collection systematically excludes populations without reliable smartphone access, without digital literacy, or stable internet connectivity, which includes many of the populations with the greatest health burdens. Studies that recruit through digital platforms are, by definition, sampling from populations with a particular technological profile. And that profile is not globally representative. Traditional informed consent frameworks designed for discrete one-time data collection events are inadequate for continuous digital monitoring that generates ongoing data streams from individuals who may not fully understand what is being collected or how it's being used. With great power comes great responsibility. Voltaire adapted. Digital tools in health research are powerful. The responsibility that comes with that power includes designing for the populations most likely to be excluded by default. Research with communities is harder than research on communities. It takes longer, it requires genuine power sharing, it produces findings that communities have shaped, which means it sometimes challenges researcher assumptions rather than confirming them. The more I know, the more I realize how much I don't know. Socrates. It's also more likely to produce findings that communities trust, adopt, and act on, which is ultimately the point. The communities with the most to gain from global research and the most to lose from bad research should exercise meaningful control over the research process. The question is not whether this is right, the question is whether institutions are willing to actually share power, rather than performing community engagement whilst retaining control. This episode is based on Chapter 3 of An Introduction to Global Community Health Psychology, Applications at the Intersection of Health Psychology and Public Health, published by Routledge in March 2026. Chapter 3 raises the question every researcher working with communities should ask: who benefits from this research? The answer has historically been mainly the researcher. This chapter is about changing that. The full textbook is available on Amazon and from Routledge. Links in the description. Episode 8 covers Chapter 5, Cross-Cultural Research Methods and Applications. The central question: why does your evidence-based intervention fail when you cross a border? If this episode has been useful to you, here's how to go deeper. Subscribe to this channel at Anaweokhai Institute for the complete books to video library from the Anaweokhai Institute for Applied Global Health. New episodes every fortnight. The Health Dispatch, our weekly newsletter, goes deeper on every topic this series covers. Free and paid tiers. Link in the description. The Practitioner's Course in Global Community Health Psychology is available on gumroad.com. 8 weeks, everything this textbook covers, built for practice. Link in the description. And the textbook itself, An Introduction to Global Community Health Psychology, is available from Routledge and on Amazon.com. Everything begins there. From the director of the Anaweokhai Institute for Applied Global Health, Port Harcourt, Nigeria, health is not destiny. It's been Dr. Anthony Iyore Anaweokhai. I'll see you on the next one.